inaugural MedEClasses postgraduate lecture series. As we discussed earlier, that pediatric endocrinology is one branch of pediatrics which is very fascinating. It has got a lot of challenges. And unfortunately, the exposure is limited in pediatric endocrinology with regards to especially the postgraduate teaching. And that's why we've taken this initiative. I am really honored to have Dr. Sonal Shah from MP Shah Medical College, Jamnagar, who has joined us as the expert faculty for this program, and Dr. Sayan Banerjee and Dr. Pratik, who are from the DGNC Center for Diabetes, Endocrinology and Research, who are part of this program. So the way we are planning is that over the next 36 months or so, we will have a session every month on one of the Saturdays, preferably the third Saturday, in which we're going to cover the different aspects of pediatric endocrinology relevant from pediatricians and postgraduate perspective. This will have a didactic lecture. At the end of the lecture, we'll also have a discussion about practical points as well as how to respond in terms of exams and these stations as well. So I'd like to invite Dr. Sonal as an expert here and share her comments. Dr. Sonal, please.
Yeah. Good evening, sir. Thank you for giving me the opportunity for the postgraduate webinar series. It has been a great pleasure to be here with a legend like Dr. Anurag sir. He's a master in endocrinology. I have done a basic course under him, and after doing the basic course, I have been able to implement so many new things in my department, and postgraduates have benefited a lot because of that. And I hope with this webinar series also, the postgraduate will learn more and more, and there will be more awareness about the endocrinology. Thank you.
Thank you, Dr. Sonal. So this program will also be available on our website in a recorded fashion as well as on YouTube. So this are all complimentary. We'll start off the program right away. So I hope the screen is now visible, and we'll start the session right away. Okay, so as discussed today, we're going to start off with the growth module, and the next 5 talks are actually on growth. We'll talk a bit about how to really measure and assess children. Then we have a session on growth chart and bone age. We'll have a second session on short stature subsequently, and then there will be an interaction between Dr. Sonal, Dr. Pratik, and Dr. Sayan about these aspects in that regards. If you have any queries or questions, you can put on the Q&A chat, and we'll address it towards the end of the session in that regards. Now, all of you can go and have a look at our website, learning.growthsociety.in, which has got multiple options available with regards to resources, which are free resources, as well as different modules. A lot of resources are available on YouTube. There are over 300 videos which are available, which are there for access, and we'll be posting this recording as well there. And you can go in terms of assess our courses, which are there ranging from fellowship to postgraduate courses as well. There are 3 specific free webinars which we conduct every month. One is related to advanced pediatric endocrinology, which happens on the 4th Saturday in the afternoon. Then we have one for the basic pediatric, which is done basically for postgraduates and pediatricians, in which we have case discussions. Today we had a very interesting case of DK there. And the third one is this, which we are starting today, which is a monthly lecture series starting for growth in that regards. There are publications which can be accessed through our website, as well as mobile application, which really makes it very easy to implement. And we'll showcase a few things with regards to growth chart and bone age today in that perspective. So this is how we plan it over the next 3 years or so. We'll start with growth assessment, followed by short stature, growth hormone therapy, obesity, and there'll be one session in which there'll be case presentations, which will be done in that regard. So this is how we plan to go ahead. Growth chart, of course, is pivotal. So when we talk about growth, and we discussed that there is a snapshot and there is a continuum. We want something which is a pictorial description, easy to plot, easy to interpret and follow up. And the answer to that is a growth chart. So all of us, when we're talking about growth evaluation of any form, short stature, tall stature, early puberty, late puberty, obesity, this is something which is the first and the primary investigation that all of you should do before doing anything else in that regards. So when we talk about growth chart, there's often a confusion as to what is a growth standard versus a reference. And this is very important in that perspective to understand. When we talk about reference, it is basically comparing to the general population in a cross-sectional database, and we actually compare the growth as it is for a given population. But often there are many factors which may influence. So there may be nutrition, which may be defective. There may be effects of other factors like infections, which may influence. So they may not represent the ideal growth. And that's why we talk about growth standards, which talk about an ideal population using a longitudinal design, providing information about ideal growth. So while reference is basically from a cross-sectional general population, standards are from what we want people to be there, what is the goal that is there. But often that may cause more confusions than in that regards. So of course, standards are better, but they are more difficult to achieve. So we'll go through it in terms of various charts which are available in terms of references and standards, and talk about the merits, demerits in that regards. So when we talk about growth chart, the first recommendation which is there for a given population is that if you're using a growth chart, it should be recent, within the last 10 years, local, within that particular area. And when we talk about local, whether we're talking about country specific, whether you're talking about region specific, become important, but generally should ideally be a country specific chart, should be representative of the population, and avoid confounders. And this is very important because if you're talking about something which may affect in terms of socioeconomic status, in terms of infections, that may cause real problems in that perspective. And that is why many of the charts, especially in the resource poor countries, are developed using affluent populations so that you avoid the effect of nutrition, because otherwise there will be a lot of confusion in defining the cutoffs in that perspective. So these are important. Very importantly, when somebody is developing the chart, there will always be people who will be very tall, very fat, very lean, or very short. So you have to remove those outliers. So there are criteria in which they say if it's more than 3 standard deviation apart, we will remove them, because otherwise they are going to cause confusions in terms of calculations. We have to consider the effect of adiposity, which is of primary importance. And then if you're talking about cross-sectional data, it may be not a linear one. It may be a zigzag one. So there are various methods by which this is smoothened. And the most commonly used method is the LMS method, in which there is correction, which provides you a very real curve in which happens in terms of growth chart. And we'll discuss this about in that regard. Now, one of the most common charts which have been used for a long time are the CDC charts, which are largely used based upon the US data. And there are various criteria and the surveys which were available as we have provided here, and based upon that, these charts have been made. So these are more like a reference rather than a standard, because they are all survey-based cross-sectional data which we are getting in that perspective. So CDS charts are largely based upon the NCHS data using middle-class individuals who are unselected. So again, it's not really providing information with regards to the ideal growth, but the actual growth which is happening. There are 7 percentile lines that we see from 5th to the 95th percentile. So we tend to know whether somebody is between 5th and 95th. And this is important to remember, because when we define somebody as short, generally we talk about 3rd percentile. So this may be a problem with this sort of a chart in that perspective. And this is a cross-sectional data which is available in that regards. Now, based upon this, to improve it further, were the WHO child growth standards which were developed. Now, these are standards and not references. And when we say standards, this is an ideal population we're trying. So this is based upon the data from 6 different countries that are trying to represent across the world, from South America, Africa, India, Europe, Middle East, and USA, a reasonable number. And they started to follow them up. So it's a long-term follow-up. Very importantly, compliant with infant feeding and no smoking criteria. So these are the ideal situation in which a Homo sapien should grow. And what they really found out was that as if you have an ideal situation, the growth is not very different, especially in the early phase of life. There may be issues later on, but early phase of life growth is consistent across the globe. And they used individuals who were singleton, normal birth weight, exclusively breastfed till at least 6 months, with no smoking as a criteria, and had normal nutrition in the family. So these were, in a way, the ideal growth circumstances which should be there for a child. And based upon that, we had these curves which were developed for the first 24 months, then up to 5 years. So this was a multicentric ideal situation, longitudinal data, which was available. And following which, there was a cross-sectional data which was merged into it. And based upon that, we have got the WHO charts. So WHO charts are both standards till a particular age, and after that, we have got more reference data which comes in. So this is something which we need to understand and understand in that regards. Now, what will be the problem if you're using a WHO growth chart in a resource poor setting like India? And this is what we have seen in our own studies, which clearly show that it will overestimate growth failure. So you will have many more children who will be labeled as short, who may actually not be short. So this may be a problem if you're using it. And this problem was seen across the globe, not only in India, but multiple centers, and you will underestimate obesity. So while, as very nicely was shown by Pratik, that there may be discrepancy with regards to body fat levels as the BMI standards are concerned. And therefore, if you're using a higher cutoff, you will in a way say so many more children are short, but not many are fat. So this may be a problem from both perspectives, and this is a big challenge which is there. So therefore, to come out of it, nation-specific charts are what are required, and the Indian Academy of Pediatrics in 2015 developed a reference data which were basically combining 0 to 5 years from WHO, because at that age, there is not much difference. And then from there were 9 studies which were conducted across the country using 33,000 subjects. Based upon that, they used some outlier criteria, and then they developed this chart. Now, if you see, for the first 5 years, there is a very rapid growth. And then the growth seems to be slightly less. This is because the first 5 years is coming from WHO. And then we are talking about the growth from the Indian standards. And this is something which can often be confusing, because your child might have been short and then suddenly becomes tall in the standards. And this is because there is a merger of data between 5 years from Indian and WHO criteria. And when we evaluated this, we found that this is actually quite good in terms of identifying both pathological short stature as well as the pathological obesity in that perspective. So the general message is that best is to use country-specific growth charts within the last 10 years, avoiding confounding factors and outliers, and this is what you will get in terms of that perspective, and this is what we found. There are also disease-specific charts for Turner syndrome, Down syndrome, and achondroplasia, which are available, which you can use for those conditions to identify whether there is an additional problem to these children. So if you have a Turner child who is not growing as far as Turner chart, maybe there is associated hypothyroidism, maybe there is celiac disease, and these parameters can be identified from that perspective. So these disease-specific charts also become important from that perspective. And as Dr. Pratik showed, there's also a growth velocity chart in which you mark the growth velocity. And as we can see, this is this typical ICP model, huge growth happening during infancy, lower growth in childhood, second peak coming in puberty, both in girls and boys. And based upon that, you want different percentile cutoffs for growth velocity. It should be more than 25th percentile. That is around 1 standard deviation score. Roughly less than 25th, you are worried. And if it's less than 10th, it is definitely something which is quite concerning in that regard. So different cutoffs. For growth, we're talking about 3rd percentile. For growth velocity, we are talking about 10th percentile, which becomes relevant from that regard. What about body mass index? So body mass index also, there are cutoffs which are available from the CDC. And again, this talks about 5th to the 95th percentile, 8th percentile lines are there. And they use criteria of overweight above 85th percentile and obesity over 95th percentile in that perspective. Severe obesity is defined if it's more than 120% of the 95th percentile. Now, what's important to remember is that if your entire population becomes obese, your cutoffs will change. So come what may, only 5% of your children will remain obese and 15% will remain overweight. So there is a flaw which is there with these regards, because ultimately, as I discussed earlier, you have to compare a cutoff to a particular complication. And if you are not comparing that, there would be a lot of confusion in that regards. So to do that, the IAP and the IOTF, the International Obesity Task Force, use a different way. They calculated at what level do complications happen in adults. So internationally, we talk about obesity cutoffs of 30 and 25. In Indian setting, we talk about 27 and 23. So 27 is considered obese and 23 is considered to be obese. So what they did was they backtracked from those figures and went back from that perspective. And this is why in the IAP chart, we don't have a 88th, 85th percentile or 95th percentile. We have 27 equivalent and 23 equivalent. And the International Obesity Task Force, which is a global cutoff, uses a cutoff of 30 and 25. So this is something which is important to understand, that we use equivalent cutoffs and not really just the percentiles, because there will be a confusion in that regard. This is the IOTF data available internationally. based upon multinational data, backtracking cutoffs happening at 30 and 25, and they tend to have a higher level as compared to the CDC in that perspective. So till now, we've talked a lot of theory. Now we'll talk more of practical issues and how do we really apply these growth charts more to the context of growth than with obesity. So first of all, select an appropriate chart. Select a chart from your country. Once you've done that, calculate the exact age because that's very important. And then when you're plotting, do not use a big dot, use a small dot so that it becomes very clear when you're plotting in that perspective. So these are the basic fundamentals in that regards. Then you're looking at three major things with regards to the growth chart. Absolute status, how tall is the child compared to the population, and for that you can use percentile or you can use standard deviation score. The second is to compare to the parental expectations, and Dr. Pratik talked about mid-parental height, and for that we look at target height and target height standard deviation score. And there are ways in which you can correct and get whether this is familial. We'll talk it more when we talk about short stature subsequently. And then the most important aspect is to look at the nutritional effect. Now, there are two broad causes of growth failure. One is a nutritional cause like malnutrition, malabsorption, celiac disease, tuberculosis, RTA, and endocrine cause, which is hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism. The main difference between the two is that in nutritional causes, it is the weight which is mainly affected. In endocrine causes, it is the height which is affected. So what you need to look at is the height and weight age. And this is the most important thing to look at in growth chart. The height age is the age at which the current height becomes the 50th percentile, and the weight age is essentially the same for the weight. So what it tells you that this child is 10-year-old, how much he is equivalent as to a particular age. He's equal to a 5-year-old child in terms of height, so his height age becomes 5 in that regards. You can also calculate BMI STS to identify this nutritional effect in that regard. So we'll start right on the practical issues now. This is a 12-year-old girl. This is the plot and this is the chart. So what we see is that this girl is definitely below the 3rd centile. So the first question is she's short for the population. The next question is she short for the family? So for that, what you do, you develop the MPH, the mid-parental height, which actually is 150 here, plus minus 6 centimeters, which gives you the range. And then you draw a line right from the top and the bottom, and you will now get the growth chart for this particular family. Now, if you look now carefully, this child is short for population, but she is not short for the family. So this is clearly a familial short stature. The third thing to look at is the height age. For that, you draw a line from the current height to the 50th percentile, draw a perpendicular and see where it meets. This will be the height age, which is 9 years, and same as the weight age, which is 9 years. So this girl is short for the population, normal for the family, and equivalent to 9 years. So this doesn't need much investigations in that regards. We have developed a mobile application in which you give us these inputs. You will get the interpretation and the diagnosis as well immediately. So all these calculations are already done by the application in that regard. So this is familiar short stature just by looking at the growth chart. Now we have got this girl, we followed up. So what we did was that now we have already known that this is familiar short stature. 6 months later, she has gained 3 centimeters. So what does it mean? That the growth velocity in the year is around 6 centimeters per year, which basically comes at the right time. So she's growing normally in that regards. Now we've got the second case, a 13-year-old boy, and we can see the height and weight are both below. Height is definitely below the 3rd centile. Very importantly, the parents are at a good height. So they are absolutely all right in that perspective. If you look at the bone age, it is slightly delayed. The height age and weight age are both delayed. And then somebody did a growth hormone stimulation, which was found to be low, diagnosed as growth hormone deficiency. Now, I would say if you look at this growth chart, the chances of growth hormone deficiency is very low because this child is just below the chart. And there can be so many other causes which can be there. And he's prepubertal with a delayed bone age. So in this perspective, this does not look like growth hormone deficiency. This actually looks more like a constitutional delay of puberty and growth because he is short for the family, short for the population, but he's not short for the bone age. So key parameter to look at is the child short for the bone age? No. So this is not growth hormone deficiency. This is most likely CDGP or constitutional delay. We'll discuss this in the next class much more. And what will happen in this case is don't do anything. Don't give unnecessary growth hormone. He will carry on growing normally to achieve a good final height. So why was this child short? Was because of the delayed puberty. And why was the growth hormone low? Is because of lack of puberty. His growth hormone did not increase. Once we did a stimulated test after a priming of with testosterone, he improved remarkably. So this is clearly again showing why growth chart is so important in that regard. Next case, 10-year-old girl, short, and the hemoglobin was low. Renal and liver functions were normal, and other workup was also normal. IGF-1 was found to be low. Basal growth hormone was found to be low, and this was the growth chart. So if you just look at this growth chart, the main question is whether it is endocrine or nutritional. So if you look at the height age and the weight age, you will clearly see that the weight is much more affected as compared to the height. So this is clearly a nutritional pattern growth failure. This is not definitely an endocrine pattern. So I would be very doubtful that this is growth hormone deficiency. Essentially, this looks like a nutritional case of growth failure. And when we did further workup, we found that the IgA levels were undetectable. And that's why the TTG was falsely negative. So this is not growth hormone deficiency. This is celiac disease, very clearly evident from that perspective. Another case, 8-year-old boy, height is 100, weight is 18, parents are normal height, other workup is normal, TTG was slightly high, diagnosed as celiac disease. Now, what we have done is that if you plot the chart, you see here that it is the height which is much more affected as compared to the weight. So this is clearly an endocrine pattern, not a nutritional pattern growth failure. And this is not celiac disease because no biopsy was done in this case. So of course, there was no response to gluten-free diet. Once we did a biopsy, it was normal, and this child came out to be a growth hormone deficiency. So if you look at the growth chart carefully, the first chart, child was short for the population, not short for the family. Nothing to worry. Second child, short for the population, short for the family, but the child was normal for the bone age. Nothing to worry. Third child had the weight age much more affected, so it was not endocrine. Fourth case, we have got the height age, which is much more affected. So this is clearly an endocrine cause. So again, if you look at the growth chart, you will get the diagnosis right immediately in terms of that. Nothing much needs to be done in that regards. Now, this is a very interesting case scenario. 15-month-old girl with a birth weight of 4 kilogram, failure to thrive. She was tall to begin with, but over time tended to fail to thrive. And by 15 months, had crossed 4 or more percentile lines in that perspective. Now, everybody got worried, and they did workup, which showed that there was a mild metabolic acidosis, and a diagnosis of renal tubular acidosis was made in that regards. The most important question I'll ask, however, in this setting is how tall are the parents? And when we look at that, she was actually an infant of diabetic mother. The parents were short. So this child was large at birth because of the environmental factor, because of diabetes. And over time, she was going to now catch down towards the parental expectation because the parents were short. The size at birth is determined largely by environmental factors. Size at final height is determined more by genetic factor. And the switch between the environment and the genetics is typically observed by around 2 years of age. So in the first 2 years of age, you may have a catch up or a catch down growth, which may happen, which is normal in that perspective where nothing is to worry. And we don't need to do much investigations in that regard. So again, growth chart will tell you a lot about the child, the need for workup, the type of workup which is required in that perspective. Now let's go to the other side. We have a 12-year-old boy. This is the height and this is the weight with obesity. Now what we can see is that the height age and the weight age both is increased. If we look at that, the most important thing to look at in a short child is the weight. That distinguishes between nutritional and endocrine. The most important thing to look at in an obese child is height. Tall and obese is nutritional. Short and obese is endocrine. So if you look at this, this child looks like a typical exogenous or constitutional obesity. Now, what happened in this perspective was that we also need to do follow-up more in terms of nutrition. But if you have a growth chart like this, a girl who had a height of 130, weight of 58 kgs, you have a chart like this. What you're seeing is that she is short. So short and plump. This is not normal. This is endocrine. And this turned out to be a Cushing syndrome. So if you have a tall and obese, this is nutritional. Short and plump, definitely you have to worry. And this child turned out to be Cushing syndrome. So very importantly, look at the height of a fat child, look at the weight of a short child, and you will get more or less in terms of distinguishing features in that perspective. So this is something which is there. So if we now move forward to another interesting case, a 6-year-old girl who presented now with tall stature. So what is happening here? This girl is looking tall and the weight is also fine. I would say the most important thing to look at here would be the pubertal status, whether the girl is in early puberty and whether she actually also had an advanced bone age. Now, what is we are seeing from the yellow dot is that her bone age is advanced. And what's happening here is that she is 6-year-old. Her height is equivalent to around 8 to 8.5, but the bone age is 11. So she has already lost 3 years in terms of growth. And this is a definite issue of concern. This girl has a clear-cut situation of precocious puberty, which requires treatment. If you don't give it, there would be a lot of problems. So anybody who has a growth failure, anybody who has got obesity or pubertal disorders, look at growth chart. That is your first go-to place.